Dr. Matthew Harer is a neonatologist at the University of Wisconsin Health and associate professor in the Department of Pediatrics at the University of Wisconsin School of Medicine and Public Health, Division of Neonatology and Newborn Nursery. Dr. Harer also happens to have went to my current fellowship program at UVA. He does also have a special interest in caring for neonates with renal conditions, including using a kidney oxygen monitoring device that detects renal injury in real time, providing prompt treatment and decreasing the rate of renal injuries in the NICU. In keeping with his commitment to researching renal injury, he also serves as the co-chair of the research committee and a board member of the Neonatal Kidney Collaborative. Today, he will be presenting on improving childhood kidney outcomes in premature neonates with caffeine and kidney oxygenation monitoring in the NICU. As you are logging in, please remain muted, but feel free to place any comments or questions in the chat. I will be monitoring the chat and we will have time for Q&A at the end.
All right.
Dr. Harris, all you.
Thank you so much. Appreciate being invited to give this talk with you guys today and talk with something that I'm very passionate about, improving childhood kidney outcomes in former premature neonates with caffeine and kidney oxygenation monitoring. I do not have any relevant conflicts of interest, and I do intend to discuss some unlabeled or unapproved use of drugs and devices. So the objectives for today are to explain the impact of premature birth on future chronic kidney disease risk, demonstrate how to measure renal oxygenation and explain normal and abnormal values in the NICU, identify how caffeine use in premature neonates affects short and long-term kidney function, and identify NICU graduates who have a higher risk for chronic kidney disease during childhood. So I like to put this picture up. This was a tomato I was cutting up about 3 years ago. And when I cut it open, I'm like, oh my gosh, this is little baby kidneys. So, you can see the nephrons, you can see some fibrosis, maybe a little necrosis in one of the areas there, but just like to start with some underdeveloped tomato kidneys. I think sometimes this is the most important takeaway from this talk, is to have a really strong understanding of nephrogenesis. So we know that nephrogenesis begins around week 10 prenatally and continues typically through 36 weeks. But we know that nearly half of the nephrons that are formed in the last trimester of pregnancy. And you can see that from this curve here. So if you think about many of our babies who are born extremely preterm, they're likely to be missing almost half of their nephrons, depending on how many nephrons develop after prenatal birth. And that's something that is still up for debate. And I'll talk a little bit more about that in the next upcoming slides. So there's where it typically would end. And in our really most premature babies, this is how many nephrons they're being born with. So a significantly less number. And we know, unfortunately, that nephrons are only lost throughout our lifetime. So after the age of 60, you lose about 4,500 glomeruli per year, which is why you see more chronic kidney disease in older patients. And you can think about all the different things that affects nephron health growing up during childhood here and during the adult time period. But we also have to think how many nephrons a baby is born with and the number of different prenatal insults that can affect how many nephrons those babies get. And you can see that list here. So potentially some of our premature babies are going to be on this more dotted line where they lose nephrons a lot faster and potentially are at higher risk for chronic kidney disease than a baby who's born at full term. And the other really key point is that nephrons do not regenerate. And the kidney is obviously different than the lung that typically would continue to develop up until 8 years of age. So one of the biggest questions is, are nephrons formed after premature birth? So Dr. Rodriguez in 2004 did an autopsy study of 56 premature infants who were less than 1,000 grams. And they found that there was no new evidence of new nephrons defined as the basophilic S-shaped bodies after 40 days of life. And that was independent of birth gestational age. So what this meant to us is that those born less than 30 weeks likely stopped forming nephrons prior to 36 weeks, leading to something that we've called oligonephropathy. So if you think about a 24-week baby, maybe they continue to develop some nephrons through then 30 weeks corrected age. So how about this question? Are nephrons normal after premature birth? In 2011, there was a study where it looked at 28 postmortem kidneys from premature neonates and compared it to 32 kidneys from stillbirth gestational age matched controls. And what they found was that 13% of those nephrons were morphologically abnormal, with a larger renal corpuscle, increased volume, likely evidence already of hyperfiltration and accelerated maturation occurring. So the nephrons that are formed after premature birth are likely somewhat different than the nephrons that are formed in utero, or at least a portion of them are likely to be abnormal. So this brings us to the Brenner hypothesis, who long ago Dr. Brenner proposed that a congenital or acquired reduction in nephron number could explain an individual's susceptibility to hypertension and chronic kidney disease. And he thought that nephrons can maintain a normal GFR by enlarging or hyperfiltering. However, this response is going to lead to sodium retention and ultimately systemic hypertension, intraglomerular hypertension causing proteinuria, and then sclerosis, ultimately leading to chronic kidney disease. So although this adaptive response is helpful in the short term, in the long term, hyperfiltration is a harmful response. So my mentor, along with Dr. Carmody, put together this great figure back in pediatrics in 2013, where you look at prematurity leading to a reduced nephron number or oligonephropathy, ultimately leading to hyperfiltration, and over time causing systemic hypertension, proteinuria, leading to nephron loss, glomerular sclerosis, and concerning then for the development of chronic kidney disease. What we really don't know, though, is what time frame this occurs for different babies born at different premature gestational ages. Or does every premature baby go through this process, and when does it occur? One really great study that was published back in 2019 by Casey Crump looked at a population-based study to determine the hazard ratio for the development of chronic kidney disease by the age of 40. And you can see from this figure here that any baby born preterm has about a 2 times increased risk of developing chronic kidney disease when they get older. But if you look at the extremely preterm population, 22 to 27 weeks, their hazard ratio for developing chronic kidney disease by the age of 40 is 3. So I feel like this is the strongest evidence that we have that already by the age of 40, you have a 3 times increased risk for extremely preterm babies developing chronic kidney disease. What I really worry about is the potential two-hit model, is that you're born with low number of nephrons, either from being born preterm or having an adverse intrauterine environment. Then during the NICU course, you have a lot of adverse neonatal exposures, hyperoxia, nephrotoxin, sepsis, inflammation, hypotension, all of those things potentially leading to acute kidney injury or a different cause of acute kidney injury. And then leading into childhood, where you have the other risk factors for chronic kidney disease. So really worried that these other NICU exposures, kidney injury, or childhood exposures could be the second hit on top of oligonephropathy that accelerates the progression to chronic kidney disease, potentially leading to symptoms as early as 5 years of age. So what is acute kidney injury? Acute kidney injury is an abrupt decline in renal function that results in a derangement of fluid balance, electrolytes, and waste products. I really like this histologic figure here that shows on the right figure, figure C, a term infant without acute kidney injury. In the middle figure, a preterm baby without acute kidney injury, already showing larger glomeruli indicating hyperfiltration. And then in figure A, a preterm baby with acute kidney injury showing cystic dilation of the Bowman capsule. Also, you can see many dilated tubules, and then the most obvious being that fibrous infiltrate, the dark red there. So over the years, what we call acute kidney injury has changed. Initially, it was called acute renal failure, and the definition was typically any creatinine over a value of 1.5 milligrams per deciliter. However, Over the years, over the past 20 years, the definition has changed and typically is adapted from the adult and pediatric literature. So we've gone through P-rifle in 2002, akin in 2004, and then ultimately in 2012, there was an agreement to utilize the modified neonatal KDIGO definition of acute kidney injury. And I hope many of you have seen this before, but this is where a stage 1 injury is a 1.5 to 1.9 times increase from baseline serum creatinine, or a 0.3 increase in creatinine in the course of 48 hours. Stage 2 injury is a doubling of your serum creatinine, and a stage 3 injury is a tripling of your serum creatinine, or greater than maximum value of 2.5 milligrams per deciliter. We also have associated urine output criteria. So stage 1 is less than a half an ml per kilo per hour for 6 hours. Stage 2 is less than a half for 12 hours. And then stage 3 is less than 0.3 mLs per kilo per hour for 24 hours, or anuria for 12 hours. In the electronic medical record, this is relatively easy to do, is to graph your serum creatinine values. Here's a sample patient in which it's very easy to pick out rises of 0.3 milligrams per deciliter or doubling. So you can see theoretically this baby had 4 episodes of acute kidney injury indicated by the gray arrows. Nowadays, we typically don't diagnose kidney injury with that initial rise. So in the first 72 hours, you allow the baby to establish their lowest creatinine. But then you can see here, this baby had a rise from 0.7 to 1.2. So that would be a stage 1 injury. Again, here, probably a rise from, again, 0.7 or 0.8 to 1.3. So still a stage 1 injury. But then later down the road in this baby's NICU course, ultimately has a doubling of their creatinine. So technically a stage 2 injury. I would argue, and I don't know that we have the evidence yet to say that, the stage 2 injury here is worse than the stage 1 injuries, where the serum creatinine rise is greater and potentially lasts for a longer period of time than this stage 2 injury here. So now about nearly 6 to 8 years ago, we developed, as a part of the Neonatal Kidney Collaborative and an NIH-sponsored work group, the AWAKEN study. In the AWAKEN study, babies were enrolled, over 2,000 babies were enrolled who had at least 48 hours of IV fluids, and we really determined the rates of acute kidney injury. So in this figure, starting at the spoke in the upper right-hand corner, the babies born less than 29 weeks, nearly half of these babies experience acute kidney injury during their NICU stay. In the babies who are a little bit healthier, 29 to 36 weeks, only about 1 in 5 of those babies develop acute kidney injury. And then in the term population that's admitted to the NICU and who are on IV fluids for 48 hours are typically more ill. So about 1/3 of those babies experience acute kidney injury. And these are the numbers that I typically quote to families at this point. What the AWAKEN study really did, though, was show that acute kidney injury is independently associated with an increased risk for mortality and a longer length of stay. Prior to AWAKEN, there was some question of whether acute kidney injury was just part of the being sick and dying process, or if babies really died because of acute kidney injury. And I really feel like AWAKEN showed, because of the large number of babies that we had, we were able to adjust for multiple other risk factors and show that babies independently have a 4.6 times greater risk of death when you have acute kidney injury in the NICU and nearly a 9-day longer hospital stay. The AWAKEN study also allowed us to do many secondary studies, and now we've published over 20 secondary studies from the AWAKEN study, and I'm going to go through these relatively quickly, but you're able to look all these studies up on the Neonatal Kidney Collaborative website, which is babykidney.org, and you can access these studies in the summaries. So first, we were able to show what the early risk factors are in the first postnatal week, what the late risk factors are for acute kidney injury. And I'll talk more about this later, how caffeine is associated with decreased incidence and severity of kidney injury, how we're actually not very good at diagnosing hypertension in the NICU, how there's associations with IVH. Babies who have HIE, we know, are at a higher risk for acute kidney injury, with about 40% of them having AKI. We worked to optimize the definition and see which thresholds are the most important for diagnosing AKI. We've shown associations of AKI with chronic lung disease in babies greater than 32 weeks and those less than 32 weeks, how fluid balance plays a role in mechanical ventilation and kidney injury, how babies who have hemodynamically significant PDAs and how they're managed can affect AKI status, an association with lower hemoglobin levels in AKI and lower albumin levels. So like I said, babykidney.org is a great place to check out and see all these different publications. So now I'd like to transition into a little bit of my own research that I've been doing on neonatal acute kidney injury. We know that some of the risk factors for neonatal acute kidney injury are nephrotoxins, hemodynamically significant PDA, anemia, and hypotension. And we know one common pathway is through hypoxia, and that hypoxia can lead to acute kidney injury. We know that oxygen levels in the kidney are really important to normal functioning, and that there's really very high variation of oxygen levels in the kidney. We know that the cortex has really high blood flow, indicated by the red here, and high oxygen tension. But then when you go down the tubules, that oxygen tension changes such that the S3 segment of the proximal tubule is at particular risk of hypoxic damage due to the low oxygen delivery, but high oxygen consumption. There are actually multiple different ways to assess kidney oxygenation. There's something called BOLD MRI. You can look at blood flow. You can actually look at urinary oxygen tension. And then the way that I'm utilizing to assess kidney oxygenation in preterm neonates is through near infrared spectroscopy, or NIRS monitoring. So what is NIRS monitoring? NIRS measures regional tissue oxygenation continuously. It has a non-invasive sensor that emits near infrared light from the source to the detector at 700 to 850 wavelength. And there's partial absorption of the light by oxygenated and deoxygenated hemoglobin in tissue microvasculature below. The formula that is used is oxyhemoglobin divided by oxy plus deoxy times 100, so it is a percentage. And NIRS monitoring in the NICU is actually most often used to evaluate cerebral oxygenation in preterm neonates. And the placement of sensors and size of babies is very important. So a recent publication out of Seattle, Washington actually showed this, where the different gestational age and size of the babies can really affect where the arc of light that goes typically 2 to 3 centimeters deep may actually read very different parts of the brain, depending on the placement, size, and gestational age of the baby. So you can see here in the smallest babies, potentially the arc of light going all the way through the ventricle, whereas if you look at the larger baby, mostly getting white matter or anterior limb tracts. So how is NIRS monitoring different than pulse oximetry? Pulse oximetry is a global estimate of the precapillary oxygen delivery and looks at data from pulsatile arterial sources, whereas regional oxygenation, or NIRS, expresses the full tissue hemoglobin oxygenation without subtraction of the non-pulsatile data. So typically what's presumed is that individual tissue segments are a mix of 20% arterial, 75% venous, and 5% capillary. So ultimately, regional oxygenation would provide predominantly post-capillary tissue oxygenation, or a surrogate estimate of local tissue oxygen utilization. So trying to put all this together when thinking about neonatal acute kidney injury, you have here the spectrum from normal all the way to kidney failure and death. And thinking about when damage is occurring, typically you don't see changes in urine output or creatinine until your GFR has already decreased. And unfortunately, the damage at this point has already occurred, but potentially monitoring kidney oxygenation allows us to detect babies who are at either an increased risk or still at a stage of reversible damage. And maybe then actually something that we can do for these babies. So when I think about renal tissue oxygenation, I like to think about it as a supply and a demand issue. So first, when thinking about supply, we need to think about oxygen delivery. Just a reminder for people to mute, maybe just hearing some background noise. First, with cardiac output, you need to think about low cardiac output states, and particularly in the preterm babies, hemodynamically significant PDAs, and when you see reverse flow in the descending aorta. A really big driver of regional oxygenation is hemoglobin, so you need to think about anemic babies or situations where there might be acute blood loss. And then also you want to think about how the renal blood flow is and if there could be a thrombosis. Thinking about oxygen consumption or demand is a little bit more complicated. You need to think about what the renal perfusion pressure is, which ultimately drives your glomerular filtration rate and your tubular sodium reabsorption, and ultimately then your oxygen consumption. So I'd like to provide here just two examples. So first, let's say you have a baby who has higher than expected renal tissue oxygenation. So this would be like in the 90s. That baby likely has normal blood flow, but likely has decreased demand. So babies that I think about in this situation are often the HIE babies who have had something like acute tubular necrosis from their birth hypoxia. They have normal renal blood flow to the kidney, but their kidney has intrinsic injury such that it's no longer extracting oxygen, so you would see higher than normal values. In the second situation where you would see normal than expected values, this could be a preterm baby who has a value less than 50%. And it might be a situation where there is a hemodynamically significant PDA, such that you have reduced oxygen delivery to the kidney, so the supply is reduced, but you have normal oxygen extraction, so you're seeing a lower than expected value. So where's the proper place to put a renal near sensor in neonates? It's really the soft spot that's located on the posterior flank below the last rib and above the iliac crest. And when you feel that space yourself, it really is about the width of your pinky, which actually turns out to be just about the size of most neonatal NIRS sensors. You want to put the tip of the sensor with the emitting light close to the spine, but not overlying it. When I've done my point of care ultrasound measurements, typically it's just 1 centimeter lateral to the spinous process. It's really important that then the cord comes off to the side. We've had numerous instances where the nurse has flipped it and the cord goes straight across the back and the light emitting is on the side of the flank, and then you're actually likely getting intestinal oxygenation and not kidney oxygenation. So like I mentioned, we've been performing point of care ultrasounds in an observational study that I've been performing to measure the distance from the skin to the superior kidneys, from the skin to the inferior kidney, and then from the kidney to the spine to really verify and validate the measurements of renal NIRS in different size and gestational age babies. In most babies that we've measured, the skin to the superior kidney is only about 0.3 to 0.4 centimeters. So the kidney is really right below the surface of the skin. And then depending on the size of the baby, the kidneys can be anywhere from 1.5 centimeters all the way to 3 centimeters. And this becomes important because potentially the near light in the smallest, most premature baby actually is going beyond the kidney and picking up intestinal oxygenation. And then I already mentioned just about 1 centimeter from the kidney to the spine. So this is unpublished data that hopefully we'll be publishing in the next year. We've also found that there's no significant differences from the right to the left side. So here you can see in red the measurements on the right kidney compared to the left kidney, and how those are not significantly different, which we wouldn't really expect them to be. So we tried to find what the strongest correlation of these kidney measurements were, whether it was for birth gestational age, birth weight, or birth length. And we actually found, and this might not be totally unexpected, is that the strongest correlation for these measurements are actually to birth length. So that might actually be the best guide to use for placement in the future. An important part of doing NIRS monitoring is protecting the sensitive skin of preterm babies. We found that using a piece of Mepitel cut longitudinally, creates about, you can use then 2 pieces, 1 for each side, and placing it under the near sensor makes it less sticky and causes less skin injury. So we utilize this on all of our preterm babies less than 34 weeks. And we actually have developed a protocol where every 6 hours with cares, the nurse will remove it and put it on the opposite side. There is a little piece of metal in these sensors at the tip that can cause bruising if the baby lays on it for too long. So we found that moving it frequently helps to prevent any erythema or bruising. So finally, what is normal kidney oxygenation in preterm babies? We performed a collaborative study with Stanford and Dr. Chalk, where we combined our data on preterm babies born less than 32 weeks with their preterm kidney oxygenation data. And what we found here in these 2 curves were that preterm babies typically see a decline in their renal oxygenation in the first 72 hours of life. We hypothesize that this is due to slowly improving renal blood flow and activation of the kidney as it starts to have an increased GFR and the babies start to make increased urine output and utilize more oxygen. We found that typically the renal oxygenation then stabilizes from 72 hours through the first week of life. These 2 curves display babies of the more preterm gestational age, so the more 22 to 27 week population typically being a little bit lower on the red, and then the dark shaded area being the less preterm babies of 29 to 32 weeks gestation. The second graph on the right just shows the percent change in renal oxygenation during those timeframes. So basically can expect a 5% decrease over the first 72 hours for each 12-hour time period. One big question that we have, and when you watch renal oxygenation, is you can see pretty major variation what the renal oxygenation is minute to minute and even hour to hour. So Dr. Mintzer did a study a while back where he looked at 24 preterm neonates with an average gestational age of 27 weeks. And he looked at the variation, and you can see here with the bar graphs, the splanchnic is this one on the far right of each of the trios. Cerebral is the first darkest bar, and then the renal is in the middle. That depending on the time frame that you look at, the variation is different, but always the cerebral has the least amount of variation. The kidney has the second most variation, and then splanchnic has by far the most variation in the percentage of oxygenation over time. There've only been a couple of studies that have looked at how the normal values differ by machine or sensor. And they've only been done in cerebral evaluations. So in the very large Safe Boost study, they needed to come up with validating numbers because they allowed centers to use different types of NIRS monitors. So you can see the Foresight, the Nero, and some of the different ones here with the different sized sensors. And they found that in general, linear relationships of the values with respect to the reference were obtained, but there were device-specific hypoxic and hyperoxic thresholds, so they created this table for people then to utilize. But I really want to point out that this has not been done for the kidney. So everything that I present as far as renal oxygenation has actually been done with the Medtronic Invos neonatal sensor. As a part of our observational study, I wanted to try and validate what renal oxygenation is compared to the oxygen value that we're getting from blood gas values. My hypothesis was, since we think that regional oxygenation is primarily a venous measurement, that I'd see the strongest correlation to blood gases that were obtained from a UVC, thinking the renal vein is closest. And potentially when the UVC is located in the right location, we'd see the strongest correlation there. However, my hypothesis was disproven, and we actually found the strongest correlation of renal oxygenation to the blood gases that were obtained from UACs or from capillary blood gases, and that we actually did not see a correlation of our UVC SvO2 to our renal oxygenation. We did in this study exclude UVCs that were either low-lying or ones that looked like they were in the right atrium, but those were just based off of x-rays, and as we know, x-ray is not super great for UVC placement. So in the future, I would hope to be able to perform this study again with a point-of-care ultrasound, showing that the UVC is in the proper position and then trying again to correlate. I think we could also possibly do this with larger double lumen PICC lines that are located in the IVC and correlate those values to the renal oxygenation. So one of my major goals of monitoring renal oxygenation is to detect preterm AKI before it happens. So in my first preterm observational study of 35 babies born less than 32 weeks, we had 3 that were diagnosed with acute kidney injury. And we found that all 3 of these babies had significantly low values, less than 50% prior to clinical acute kidney injury. So we made time 0, the time that their serum creatinine met AKI criteria, and looked backwards at their renal oxygenation and see that all of them were well below 50% in the 48 hours preceding. It is interesting that actually their renal oxygenation starts to improve even before they met serum creatinine criteria. And I wonder if in these babies already their urine output had started to drop off, and the team had made some interventions, whether it was giving fluid boluses, giving blood, or treating the underlying cause that already caused the renal oxygenation to increase before their serum creatinine had met AKI criteria. When we looked at the 32 babies with no AKI, their average renal oxygenation in that first week was 60%. And when we looked at the babies with AKI, they had significantly lower oxygenation in that first week of life at 32.4%. So showing pretty significant differences in those who develop AKI in that first week. We recently, again, with our data that we combined with Stanford that actually was just published this month, showed that a decrease of 10 percentage points in your mean renal oxygenation was associated with a 1.7-fold increase in your AKI risk in preterm babies who are born less than 32 weeks. So here at UW, we've instituted standard NIRS monitoring guidelines for our preterm babies. And just to give our providers some sense of what to do with abnormal renal oxygenation, we said the first step would be to evaluate urine output and consider sending a serum creatinine. If the NIRS remains below threshold, which we've defined as less than 50%, need to consider if the baby could be anemic and might benefit from a blood transfusion. If the baby has a large murmur, do they need an echo, and could they require treatment? Typically here we utilize Tylenol. Could the baby be hypotensive? Pretty easy to figure that out. And if they are, considering a bolus or vasopressor support. And then if the NIRS remains below threshold for 30 minutes, we consider further evaluation. Do they have acute kidney injury? Are they on nephrotoxic medications? Do they need a renal ultrasound? And then the other thing that we figured out is many of our babies with acute kidney injury early on have some relative adrenal insufficiency, kind of around the 10-day mark, often getting hydrocortisone and then seeing some immediate improvement in renal oxygenation. So transitioning a little bit from the NIRS story to caffeine, I've been involved in a number of studies where we've looked at how caffeine can affect acute kidney injury. So we've shown that caffeine has been associated with improvements in short-term kidney outcomes. So in a secondary analysis of the AWAKEN study, we found that the number needed to be exposed to caffeine to prevent 1 case of early AKI in the first week for less than 33 babies was only 4.3 neonates. And in those less than 28 weeks gestation was only 2.2 neonates. So pretty impressive data right there. And the mechanism of caffeine or methylxanthines protecting the kidney is likely by blocking A1 and A2A adenosine receptors that decreases renal vasoconstriction and decreases tubuloglomerular feedback in response to hypoxia. The other data we have about methylxanthines is really in babies with HIE. And actually the KDIGO group, which is the Kidney Diseases Improving Global Outcomes group, recommends a single dose of theophylline within 6 hours of birth for babies with HIE. However, and the data backed up by a recent meta-analysis that included 6 trials of over 430 term neonates. and the pooled estimate showed a 60% reduction in the incidence of AKI in the neonates with severe birth asphyxia. However, all of these studies were done in babies who were not undergoing therapeutic hypothermia. So we really need trials and PK data in cooled neonates. I know of one ongoing trial right now where they're collecting this data and utilizing theophylline in babies who are undergoing HIE or undergoing therapeutic hypothermia for HIE. There has been some other publications from Dr. Koch at Stanford where they utilize aminophylline and aminophylline use in neonates with HIE who are undergoing hypothermia was associated with an increase in urine output and a decline in serum creatinine. So I wanted to look back at my observational study and see how caffeine affected the renal oxygenation of these babies. So we looked at babies who were just receiving maintenance doses of caffeine. We defined a baseline renal oxygenation in the preceding 6 hours and compared it to then different time frames, hourly averages after the dose of caffeine compared to the baseline to see how renal oxygenation changes. And what we found was that the babies who have the lowest renal oxygenation, most of them less than 50%, had pretty significant increases in their renal oxygenation as high as 12 to 15% after the dose of caffeine. But again, this was only in 35 babies. So in another prospective observational study that I'm doing where we had over 60 babies, 62 subjects, we did another similar evaluation. So in this, we looked at, again, different subgroups based on their baseline oxygenation. And in the subgroup that had less than 30% oxygenation, we had 16 doses in 11 subjects, 30 to 40%, 21 doses in 15 subjects. In the 40 to 50% subgroup, 47 doses in 28 subjects. And most of the babies actually, prior to the dose of caffeine, had an average greater than 50%. So that was 422 doses from all different 62 subjects. 28 of the subjects never actually had a renal oxygenation that was less than 50%. So what we found, and this is just looking at the subgroups here, less than 50%. So the babies with the lowest renal oxygenation with an average baseline of 22.3% at all time points except the 30-minute time point, the shading green shows significant increases in their renal oxygenation, and actually such significant increases as that gets them back into the normal range above 50%. And this seems to last for close to 6 hours and peaks around 2 to 3 hours of age, or 2 to 3 hours after the dose of caffeine. And then for the babies 30 to 40% and 40 to 50%, at all time points, they had statistically significant increases in their renal oxygenation, and again, persisting for 6 to 12 hours, and all then above 50%. So what happens in the babies who already have normal renal oxygenation above 50% when they're receiving their caffeine? You can see here in the red, they actually have statistically significant decreases in their renal oxygenation. However, I don't think these are clinically significant drops. So here you can see the average is 70% before the dose of caffeine. And then at 2 hours, it goes down to 68, 3 hours, 65. So really only a 5-point drop in the renal oxygenation in this group, and still well above the normal cutoff of 50%. So although statistically significant, I wouldn't say that this is a clinically significant decrease in your renal oxygenation. So really, this leads me to my hypothesis that in a healthy preterm neonate, circulating adenosine levels are low. There's not any vasoconstriction to renal blood flow, so their measured kidney oxygenation is normal. However, in stressed preterm neonates, they have high adenosine levels. They are experiencing renal vasoconstriction through the adenosine 2A receptor, and then we are seeing hypoxic or kidney oxygenation values less than 50%. But in the caffeine-treated stressed preterm neonate, again, high adenosine levels, but when they're on caffeine or have a recent effect of the caffeine is blocking vasoconstriction at those adenosine receptors, and we're seeing a nice normoxic response to that. So because of this data, I recently have proposed R01 where I would like to do a randomized prospective trial where we treat babies who have kidney oxygenation less than 50% or kidney hypoxia with different caffeine doses. So first with a 10 per kilo bolus, a second group with 20 per kilo, and compare them to babies with placebo, and looking at both kidney outcomes, changes in kidney oxygenation, as well as AKI and biomarkers, but also how this extra caffeine affects the brain, and then doing some PK and PD studies. So this is my ultimate goal here, is to do a prospective randomized trial to see if we can improve clinical outcomes with extra caffeine. So finally, in the last few minutes, I just want to transition to thinking about the follow-up of NICU graduates who are at high risk for chronic kidney disease, ultimately looking to prevent babies like this or kids like this who are on dialysis and need a kidney transplant. So the current recommendations are from the American Academy of Pediatrics to do a blood pressure screening at every health encounter in children younger than 3 years if they have a history of prematurity or other neonatal complications requiring intensive care, because these children have a increased risk for hypertension. I think most of us can admit that we're not counseling our graduates from the NICU that they should be having a blood pressure checked at every healthcare encounter. And I know my experience here in Wisconsin is that when we make that recommendation in the discharge summary, we get a lot of pushback in the kids who are under 2 years of age that they don't have the proper equipment or time or ability or resources to obtain those blood pressures. And unfortunately, I think even just those blood pressure screening recommendations aren't enough. And I think because we know that children with moderate CKD are going to lose 1% of their kidney function each year, and even children with normal kidney function but some degree of kidney damage have a 10 times increased risk of developing end-stage kidney disease before the age of 40. And we know the rates of chronic kidney disease in NICU graduates will increase over time, particularly if they develop additional risk factors. I think we can do something about it, though. I think we can be more knowledgeable and be better about counseling families and developing screening recommendations. And we could have a big impact in the future on the rates of chronic kidney disease, particularly in our NICU graduates. We do know that there are some interventions out there, and hopefully more coming down the road, like ACE inhibitors, avoidance of nephrotoxins, blood pressure monitoring and control that can support kidney health and prevent or delay the progression of chronic kidney disease. So what are the next steps? One of my colleagues, Dr. Starr, is hosting a meeting funded by an NIH R13 grant to convene interdisciplinary expert conference actually next week to develop consensus follow-up screening recommendations. So I can't do this work without a big team called my research group, the Iconic Research Team, Improving Kidney Outcomes in Neonates into Childhood. And all of these different individuals have contributed to our research. Of course, have to thank my family, my wife and my kids for giving me this time to be able to do this work. You really need a strong mentorship team. Mine consists of Dr. Charlton, a pediatric nephrologist at UVA, Dr. McAdams, a neonatologist here at UW, Dr. Chalk at Stanford, who has been my NEERS expert, Dr. Capitini, who's taught me how to write grants, all my mentees and my funding from those multiple different resources there. So with that, I would love to answer any questions that you guys might have.
Thanks, Dr. Harer, for that great talk. I did put a link in the chat to everyone to provide any feedback and a follow-up survey on today's Online with the Experts. While everyone is thinking of questions, I did have a couple, Dr. Harer, that I wanted to ask. So you had mentioned that within the first 72 hours of life for preterm infants, their creatinine could be a reflection of maternal creatinine, and you want to kind of wait until the baby establishes their own creatinine. How would NARES be a way to evaluate for acute kidney injury during that 72-hour time frame while you're still kind of waiting for the baby to establish their own creatinine?
Yeah, I think that is actually a really great idea. We haven't done that because typically for my research studies, we try to obtain consent or before 96 hours. So most times our sensors are going on at 3 to 4 days of age. And I found that also in the most preterm babies with the highest risk of skin issues, that actually that gives that first 72 hours a little bit for the time or a little bit of time for the skin to mature. So I worry a little bit just about using the near sensors in that really early time frame, but the Safe Boost study really did it safely by monitoring cerebral oxygenation in that first 72 hours. So I've just always erred on the side of caution with not putting them on super early, but I certainly think that would be a great way to potentially really assess kidney health in that first 72 hours when the creatinine is not super reliable.
Yeah, that's a great point that I didn't even think of, is the importance of skin integrity, in addition to being able to monitor renal perfusion. Um,
And if we have any engineers in the audience, we really need to design like a micro near sensor, because even the neonatal sensor, unfortunately, is relatively large. And in the smallest, most premature babies who are like 500 grams, I think that sensor is sometimes just too big. So if they have umbilical lines that are secured, it's sometimes hard to wrap the sensor around and get appropriate readings as well.
we do have a couple of questions in the chat. One is about the level of anemia. And have you found that based on the level of anemia, it compromises kidney oxygenation? And does the transfusion threshold um, kind of link to that as well?
Yes, that is a really great question. I'm just seeing if I put our I don't think I put our preliminary data. So we've started to try and answer that question, and we have found correlations with increasing level of anemia and decreasing renal oxygenation. We haven't come up with a specific cutoff, though, of where really your hemoglobin or hematocrit needs to be to have normal renal oxygenation. I actually just recently got a commitment from a first year student who's going to be doing a summer Shapiro project, and she's picked that topic as the area that she wants to investigate more. So hopefully I'll be able to answer that question a little bit better in the future, but I absolutely know that it does have a major effect. We have some attendings who are actually using renal oxygenation as their deciding factor on when to initiate a transfusion. So if you're on the fence about a baby, who has a hematocrit of, I don't know, 25 to 30, and you can't decide whether giving them a transfusion is the right thing to do or not, I have some attendings who are putting on renal near sensor to decide, do they have normal renal oxygenation or abnormal renal oxygenation, and using that as kind of their deciding factor on whether or not to give the transfusion.
We have another question about the severity of AKI and what outcomes those are associated with, and which infants are screened for AKI with NEARS, such as are you screening all infants with HIE, um, um, uh, small babies with sepsis or concern for PDA or with NEC? What patient population are you using?
Yep, great question. So the studies on neonatal AKI and linked to long-term outcomes are really very small studies that just start to give us a glimpse at what the relationship can be between AKI and the development of chronic kidney disease. So, for example, I did a project during fellowship where we had babies come back between the ages of 2 and 6 who had acute kidney injury in the NICU, and compared to them to babies who did not have acute kidney injury in the NICU. And we found about a 6 times increase in the rates of proteinuria, hypertension, and reduced GFR in the babies who had had acute kidney injury. And in those babies, it did not matter what the level of acute kidney injury was, whether it was a stage 1 injury or a stage 2 or 3 injury. So I think even a stage 1 injury could potentially lead to long-term complications, but we definitely need more multi-center, good prospective data to prove that. I also think that we might in the future actually be able to come up with a better definition of AKI in the NICU, and maybe it is based off the rate of serum creatinine decline over time, or maybe we need just different gestational age cutoffs to define kidney injury. So I think there's a lot more work to be done to correlate to long-term outcomes, and develop the best definition. As far as what we're doing for standard renal NIRS monitoring, we have about 4 different groups that we do standard NIRS monitoring on. So any baby born less than 32 weeks, we do renal NIRS monitoring until the babies are on fully fortified feeds, off of IV fluids, off of nephrotoxic medications. And then as long as they don't have concern for a hemodynamically significant PDA, we stop monitoring them. In babies with HIE, we do monitoring through the first MRI that occurs between days 3 and 5. In babies with cardiac issues, we have renal NIRS monitoring in place. And then in babies who have shock and are on vasopressors, we have renal NIRS monitoring in place. And those are kind of our standard groups. I think you could consider NIRS monitoring in just babies with seizures, particularly cerebral monitoring. I think babies getting blood transfusions or deciding about a blood transfusions are an interesting group to think about. Babies with sepsis, and babies who are on nephrotoxic medications.
Kind of going off of that question, we have another question about evaluating serum creatinine and BUN during those first 72 hours. And should we be worrying about the creatinine going up? And if it trends up initially, but then starts to come down after 72 hours, are we still considering that a reflection of maternal creatinine?
Yeah, that's a really great question. And I still would love to find the data to be able to do a study to see if preterm, particularly extremely preterm babies' serum creatinines actually do correlate to maternal creatinine. So if you actually take the time to look at all of your extremely preterm babies and look at what the mom's creatinine was before, you can actually find a lot of discrepancies. So babies who have values of 1.2 and the mom's where it was at delivery 0.6. So I'm not totally convinced that story is over and that we might need to look at that a little bit more. And then we might be able to understand a little bit better if there truly is kind of that increase that is concerning in that first 3 days of life, or whether that's not actually concerning, or if that's more a reflection of fluid balance in the first 3 days. It really is a conundrum, and I don't think we know the answer about whether that first 3 days rise in the babies who are typically less than 25 weeks is really important or not. And I haven't found a way to prevent that rise. It happens in almost all of those extremely preterm babies. And I think that definitely is a future area for study.
One question about placement of the NIRS monitor and whether or not values depend on whether or not the infant is supine versus prone.
Yeah, great question. I have not found in our data a difference based on the baby's position. We have thought about whether or not things like hyperbilirubinemia can affect the reading. I think when you have the probe on the left side in the early days when the baby is still passing meconium, there's some question of whether the meconium can interfere with the NIRS light, if it's going through the kidney and even reading some intestinal tissue. So yeah, I think that would be a fun study to do, is just look at the different positioning of the baby and how that affects renal blood flow. Another major question in my mind is, does the cyclic feeding of every 3 hours affect renal blood flow? So we know we see changes in intestinal blood flow, but does renal blood flow change based on when the blood maybe is redistributed to the intestines a little bit more after feeding? So I still think there's a lot of things we can do to really understand the changes in renal oxygenation and validate it as a important reading.
And then for your R01, you mentioned that you were gonna look at giving caffeine to help prevent renal injury. Do you have previous studies? Or are you planning on collecting caffeine concentrations during your study? And then would you be giving standard doses of caffeine like we would give for apnea of prematurity, and then a study drug on top of that? What are your plans for giving caffeine in your study?
Yeah, such great questions. And I would love to share, the 100-page proposal with you to show you all the things that we looked at and thought of. But that is definitely one thing that we've thought of. So we are planning to obtain 3 different caffeine levels throughout that first 10 days to look at what the pharmacokinetics are of giving an additional bolus of caffeine on top of the babies already being on their standard maintenance and receiving a bolus in the first day of life. So our plan is for the babies to receive on the first day of life a 20 per kilo standard bolus. We utilize 8 per kilo as our standard daily dose. So the babies would be on that. Then on day 5, say they develop renal hypoxia, they would be randomized to receive either 10 per kilo, 20 per kilo, or placebo. So we will look at then what the caffeine levels are at the time of kidney hypoxia. And then we will look 6 hours after the baby receives the additional caffeine bolus to make sure that we're not getting into a toxic threshold. We performed a simulation on over 300 babies to show that less than 1% of the babies would be at a toxic, what's considered a toxic caffeine level of over 50 by giving that additional bolus. And when you really dive into the caffeine literature, there's there's several studies that have looked at levels when babies are receiving even up to 20 per kilo daily. And those babies really did not have a lot of toxic levels or side effects, but we are going to carefully look for side effects like tachycardia and things like that.
And then in the last 3 minutes, just one more question about hypoxia. So you mentioned that hypoxia is associated with acute kidney injury, but we know that hyperoxia on the other side of things is also potentially deleterious to preterm infants, especially related to things like ROP. Have you guys looked at hyperoxia at all? Are you planning on looking at hyperoxia and the effect on renal perfusion?
That is such a great point. It's always good to remember that balance, that just because a little is good, more is not better. And we have started to look at it. We typically in the preterm babies are not seeing a lot of them with renal oxygenation above 80%. But that doesn't mean that they might not still be having hyperoxic injury at that level. We haven't found a good way to kind of determine if hyperoxia could be causing injury to the kidney at that level. So hopefully in the future, we're going to have a better way of looking at that. But right now, I don't have a great way to determine if they are experiencing a hyperoxic injury. I also think it just would be hard to titrate, things like FiO2 to kidney oxygenation instead of what it is in your bloodstream, since those studies have already been done. But it is something, as we do our caffeine studies and our interventional studies, that we need to be aware of and keep looking at. So appreciate you bringing that up.
All right, sounds good. Well, if there aren't any additional questions, I'm just going to repost the link in the chat to the survey. And then the QR code is also on the screen as well. If you guys could fill out the evaluation. Thank you.
All right. Thanks everybody for
Thank
your
you,
time
Dr.
today.
Harer.
Have a good afternoon.
You too.